and then Dr. Cook, who's my attending. She's my boss. My boss's boss.
Okay.
So I kind of got the story from the night team. If I can figure out where the light switch is.
I don't know if there is one. I think it's back there.
Alright,
Above my head or something.
Alright,
I find something strange.
Oh,
That'll work. That works
Better
for
than-
you.
So I got the story from the night team about, we went to the hospital for weakness. How much have they told you about what they found in the plan and all that?
Yeah, I've talked about 10 different people, and it just,
I know.
So, seems like they're just, needs to they need to get rid of it or move it or
Yeah. So there's a bunch of spots on your spine.
When we say a bunch, how many?
I think the CT itself said numerous masses. I don't think they put a number on there.
Well,
I'll find it for you.
Yeah, if we could identify exactly.
Yeah.
I mean, at what point do they not consider it actual growth? Like, there's probably got to be a size where they consider it.
Yeah.
Just,
that's a fair point. I'll find out.
Okay, please.
But has anyone from neurosurgery come to talk to you?
No, that's what I'm waiting for.
So
you're not neurosurgeon?
No, I'm not.
What is your title again? Or?
Internal medicine.
Okay, yeah.
So
So I did speak with a couple others last night.
Yep. They're the night team.
I mean, I don't know. I guess I don't know how you guys all work, but I do believe you collaborate as we gather. But
so we kind of handle management of care, if that makes sense. So
sure.
Other people will do their part, but overall, kind of it's our decision. We're the primary team.
Okay.
But I did talk to neurosurgery. They're planning as of right now to take you to the operating room on the 28th, which would be tomorrow.
Correct.
I saw you meet Dr. Connector or Dr. Pate. He's an oncologist.
Okay.
He ordered a bunch of cancer markers in the blood that can kind of help us differentiate what these masses are.
Okay.
CT was able to, it's good at telling us where they are, but it's not very good at telling us what it is.
Mm-hmm.
And the idea is a neurosurgeon will come and reevaluate you, and if the plan is to still take you to the operating room on the 28th, at that point they'll send some stuff off for biopsy, and between the biopsy and between the tumor markers that the oncologist sent for, the oncologist will be able to make a diagnosis, and that'll kind of better dictate the treatment plan. But the reason that they're going in now is they think that the weakness that you're having is because one of the masses, is pushing on the spinal cord.
Correct.
And so that should be able to relieve, hopefully, if everything goes well in the operating room, your urinary symptoms and the weakness.
Correct. Okay.
So that's where we're going to start. And then after that, it'll be between us and the oncologist to kind of coordinate.
What's the oncologist and what do they do?
Oncologists are the people who manage malignancies or cancers. They're
So they're cancer?
Yeah, they're cancer doctors.
And okay, I think I spoke with some of them, right?
Right. And so
gotcha.
They're not ready to call it cancer just yet because
Correct.
they don't know what it is. But they're kind of in the process of sending stuff out and working it up to determine if, because they also are suspicious. You don't have a history of anything like this in your family, right? With multiple spots or anything like that? No? Okay. There are some rare genetic diseases that might manifest like this, but they're testing for all that. So we'll have an answer fairly soon here between that and the operating room.
On the blood?
Yeah, on the blood, yeah.
Okay. Well, I have kind of a group consensus with our progress, and it's not just me, but I do feel that even after speaking with many of internal medicine, and just that they are leading me to believe that we kind of established the process that we want.
Okay.
And that's kind of what I think we're going to do anyway. We will listen to all details, but our basic approach of looking at all this is least invasive process with most either information or if
the
we can
highest
do
results.
Yeah, and we at this point, I mean, I got to speak with my family, but we are feeling more comfortable about seeking more like the radiation therapies and just still going after the masses aggressively. But we probably feel that it's best to start with finding out
what it is
from a biopsy.
I hear you.
So that's, I think, that's, I don't know what our options are with that, but it just seems to, to go in there and just do, initially now if I can speak with neurosurgery.
They'll be in later. I'm in early today.
Gotcha. We want to get, I have a lot of questions as far as risk factors, outcome, percentages of this, and just many things to weigh in to our specific process. And if that is more of a comforting thing, or we feel that we have the right team, because this is because as I've learned, this is a pretty, it's not as simple of a surgery as I initially kind of thought. Because when I first saw it, like, either way, I was a little bit introduced that it's kind of serious. So that being said, to just go in and hope that it works with the ramifications that could apply, we feel it's best to just start small with, because I think it would give us the most overview data with the biopsy, something minimal, and we still hit the, we're definitely understand the time frame and concern, but we are seeking, either trying to keep my muscles going, doing obviously steroidal Band-Aid helping that just so we're definitely understand that we can't just sit around for weeks just letting this, but and I said it's not just me.
Sorry, I'm new to the case.
Sure.
Is we like you?
Me, my mom. I got like literally like 10 people. Well, at least 5 or 6 other people that are. We're a big close family. So they're like, we're not doing anything until we all decide, and we're all pretty much are kind of gearing toward. We understand the urgency. And but we still don't feel we have all the details. We speak to the neurosurgeon. Exact processes, risks. And then maybe if they kind of open us a little bit more up to whatever we feel we need answers for. So, and like I said,
is this inclusive of the surgery for tomorrow as well? You guys want to know more before?
Yeah, we're not going to just go through surgery without kind of at least considering the biopsy first.
Well, the biopsy, I think, from my understanding, you could accomplish both. 2 birds with 1 stone, but the surgery is more just because the weakness is going to get worse. We have to relieve the tension on the cord.
I do understand.
So if we wait, it would be worse. Can't say for certain, but I would say the odds definitely aren't in the favor of it getting better the longer we wait.
I totally get it. I did have some, concerns or questions about the application of, obviously I'm not professional, but there are things that I would feel like a question I had, and I don't know if this would apply to you, maybe because you're internal medicine, that I feel the steroid is a strong point to use for our time to kind of
why you make a decision, bridge you?
Not a lot, but from what I've been asking a lot about the steroid. But one thing I thought, like, why isn't it possible that instead of just putting the steroid in my IV, because that's great, but I'm sending the steroid to other parts of my body, my eyes, my feet, where we could do more of a minimal, less potent injection, but do them closer to where we're actually trying to administer, or near the growth.
I think that's a good thought, but the problem is that it's such a sensitive spot.
You can't just stick a needle in.
Well, yeah, I don't think you're going to find many doctors who are willing to stick a needle into your spine and give you a steroid. It's a very...
or not into the spine.
Or like very, very close to it. It is right up there.
Like there's got to be some open flesh areas. And I'm sure it does get to your body, even if you do it in an IV, but... It's
actually easier to get to where it needs to go through the IV because it gets into your blood circulation, and we know that that part of your body is obviously perfusing.
Right.
So we know that it'll get to it. It's a good thought because you don't want systemic steroids have their own risks that come with it, but it's just if it was somewhere more if it was one spot somewhere easier to target maybe, but it's in a pretty hard to get to spot. Usually neurosurgery is not really first on the list to call unless it's a really really tough spot, and yours is a pretty hard spot.
What size team is the neurosurgery, and how many are actively involved? And is there like a manager? Is there like a role of
so there's one neurosurgeon, and then he I think their team has two or three PAs.
So is there like a head one that he's basically the boss or whatever I call it?
Yeah.
And then there's his team. Is that kind of how?
Yeah. So the neurosurgeon who's assigned to you. So there's a group of them. Whichever one is assigned your case, they'll be the boss. So it's quote quote.
Yeah.
And then, but the people who come and see you kind of day to day are most likely is PAs or physician assistants.
Mm-hmm.
They'll kind of be who you'll have the most face time with, I would say. But he'll be the one operating.
Okay. And what would his title be?
He's I don't know that he has a title. I just think he's called the neurosurgeon, like whoever the neurosurgeon is.
But wouldn't he have like I'm going to be leading the operation or something that?
Yeah. Well, I mean, he would be, but I don't know that they carry a special designation. We just call him the neurosurgeon.
Okay. But maybe 3 at least.
3 neurosurgeons.
Yeah.
Or 3 people.
Like I mean, basically, how many people are operating? I mean, not the assistants, but I mean, who's kind of running? Just get an idea of how big of an operation this is.
Oh, I see. Well, you have 2 doctors in there. One's the anesthesiologist, right?
Gotcha.
And then one's the neurosurgeon. And usually there's, I think, just one. But I will be honest, and that's not my field.
Right.
So it's probably a question.
What was your name again?
Dr. Kondavali.
Okay, nice to meet you.
Nice to meet you. That's a good question for them. I'll be honest, I try not to get in the operating room as much as possible, so it's not my cup of tea. So that's when they come around today, make sure you ask them that, and they'll
definitely
have an answer. Yeah.
So like I said, we're open and willing to move forward, but we need a little bit more information pertinent, where we already feel we have the information with the biopsy, and I do understand killing 2 birds with 1 stone, but due to the significant risk factors that we are not yet being completely informed on, once we're a little bit more informed on the actual
so the risk factors as it pertains to the actual surgery,
a lot of things, like for instance, are they going at, I know that they were talking the T10 and T11, right? Is the area where the most mass is. The other ones are minimal, or at least not.
Or they're not as big.
Yeah. So that's they're not any bigger. So like in that region of the body, first of all, what are the actual factors? It'll be pretty damning to do all this surgery and it doesn't change any of the neurological growth pattern, so not that it isn't, but is there any kind of and this would probably just be like a biological classification, like your T1 operates your site and different. So do they feel like how versus just looking at it? Is there some type of graph or something that shows definitely, okay, this affects this region?
So kind of.
And what other regions are there in there that, let's say there's somewhat of a misstep or just any complication, could I be inhibiting or damaging or risking my eyesight or just other? That's what I want to know. Like what is the cautionary in that region?
Right.
What exactly are we going with, or what's the damage?
Yeah, I hear you. So the way the cord kind of works is everything above a certain, so let's just pick a number like T4, right? If your T4 is injured, you'd be anything that's controlled from T4 down would be injured.
So so it's more of a physical location.
Yeah. So the way that
versus-
the way it works is kind of you have the nerves from each part of your body. They go into your vertebra,
Okay.
right, and then they enter at a certain spot.
Okay.
And so as they continue, as different parts of your body keep entering the
Kind of
spine,
like a tree.
exactly like a tree. And
You basically have that'll. So it's, I think sense because why would the bottom one run your eyesight, etc.
Exactly. So, and kind of T10, T11, and then L1, L2, L3, L4, L5. They kind of do everything from, if I remember my anatomy correctly, it's like T10 is periumbilicus down. So it's like everything from about mid umbilicus down.
Okay.
So you'd still have
I see.
like hand and eyes and all that stuff, but there's more to it than that.
Yeah.
This is like the very, very, very like 10,000 foot view of it. But
like how many nerve endings and what, how many are there and what, maybe there could be minimal complications, but what are the risk factors to end up having, I all of a sudden don't have use of my spleen or something, I don't know.
Oh, I see. Yeah, so I will come back just to explain it to you a little bit further. There is an emergency in another room. I've got to run real quick, but it's nice. I'll be back.
Awesome.
I'll be back in 10 minutes.
Hey, could you do me a small favor at all?
Yeah.
We're just trying to obtain a few pertinent photos. We were going to get it last night, as we did speak with either internal medicine. They put it up on the screen, but we would really like, just for our own peace of mind and just visual, because it is my body, and a visual or maybe 2 or 3 JPEGs of the MRI or CAT scan that we could look at. Is that at all possible?
It is. I don't know if it is possible, but it's like it's a moving image, so I don't know if a JPEG would be possible, but maybe a CD
or just a
or
small,
something, or like maybe like a
video and
USB
text
or
it.
something that'll.
Yeah, or even it just be put it on the screen and take a photo or do a short 2.
Let me see if I can find a laptop and I can bring it to you.
Oh,
and
that'd be cool.
That way you guys I can show you.
Perfect.
And then if you guys want, you guys can take pictures of it or something. But
Yeah,
it's easier to see when it's a moving picture.
Yeah.
Because the way the image is done,
Gotcha.
it's like a set of like 1,000 pictures that go really, really down your spine. So it's easier to see all at
and
once.
one last thing, I gotta go.
Yeah.
Was there any real value in what the findings were with the MRI, contrast, and CAD, or the
or the CT scan?
Yeah.
So MRI is a lot more sensitive for soft tissue, nerves, things of that nature. CT is bones, masses, bigger things like that. It's good at telling us what's there anatomically, but kind of composition, the more soft stuff, ligaments, nerves, spine, things like that, and MRI is better. So usually it's harder to do an MRI, just the nature of the exam is harder. And so we do a CT first, and then if we...
Well, we did MRI first.
Yeah, well, when someone has nerve damage, with weakness and things like that, we do the MRI because we know we're looking for a nerve. But usually we look for a CT and we say, hey, there's something here, it might be pressing on a nerve, we can't see that, let's get an MRI. And so that's kind of how we escalate. So there is benefit to having both.
Okay.
But for you, an MRI
was there any significant findings from all 3, or is it mostly, and I get it, maybe you don't see everything you need and you got everything from the one, but
it's like putting it's like each picture, the best way to look at it is each image is a part of the puzzle, and that you put them all of them together, that's how you get the image. So it's not like one tells us something that the other one doesn't tell us. It kind of, you put it together and you get a better picture.
Yeah, so if you could maybe give me just a quick overview on that on the laptop.
Yeah.
Anything that I can just kind of put a peace of mind or understanding to what we're looking at. So awesome.
Absolutely.
I'll be
all
here.
Right, man. Yeah, you're good. I'll be back. Okay?
Nice seeing you.